trust building with the public. I am Cynthia Bauer here from the College Park School of Public Health Center for Health Literacy with my co-moderator Lisa Bress. I would like her to briefly introduce herself.
Good morning and welcome. I'm Lisa Bress from the School of Dentistry of the University of Maryland, Baltimore.
And we have 3 panelists. We're expecting a 4th, so hopefully she will be able to join us sometime during the session. So I don't know. Can the AV turn up the volume a bit, or is this on? Hello? Hello? All right. Okay. All right. Well, we started our panel. How about that? So I'm Cynthia. This is Lisa, and we have 3 very interesting panelists here for you today. We hope a 4th will be able to join us before the session is over. And I just wanted to say a little bit about our format. We hope that there will be plenty of time for interaction with all of you. Our format is to start, first of all, with a data presentation from Megan Humphreys from Edelman Public Relations, and then we will have several discussants reacting to Megan's presentation and talking from their own perspective about health and science literacy. Lisa and I have a couple of prepared questions to follow up on that, and then we will open the floor to all of you. So think about your questions, your comments for any of our panelists, and we hope to have plenty of time for that. So I just wanted to say a little bit about why this panel, why this theme, why these presenters, so you have a little bit of context. So I'm the director of the Center for Health Literacy here, and I am very fortunate to have Dean Lushniak as a partner in believing that health literacy is fundamental to everything that we want to accomplish in public health. That if we're not dealing with the knowledge, the skills, the attitudes, the resources that people need to do, as Dr. Besser said, live their best lives in a social and environmental and economic and political context, then we're not really dealing with this. So health literacy, if you walked into this room thinking that health literacy is about reading, I hope in the next 90 minutes that we will convince you otherwise, that it is a far more subtle, complex, nuanced, and difficult undertaking, and I hope all of you, if you're not already committed to improving health literacy, you will be when you walk out of this room. So science literacy, of course, is connected because there is a lot of health and medical literacy issues. There are many health and medical literacy issues that are informed by science literacy. So if we are trying to explain evidence, for example, how did you arrive at a particular set of data, you have to rely, to a certain extent, on people's understanding about how those data were derived. Numeracy skills, probability, all of these things are related. And so we felt it was important to bring health and science literacy together into this discussion, and then to talk about them in terms of trust. We live in interesting times in which trust is not something that's taken for granted. People trust different sources, different ideas, different people for many different reasons, and trust is a fundamental concept in communication research. So what you're going to hear is a little bit of research, a little bit of practice. So our panelists, our discussants are going to be talking from various practice-based perspectives. And what we hope is that this creates this dialogue between research and practice so that you also begin to think about both the research opportunities as well as the practice opportunities from this core notion of trust, which is not often discussed in public health research, but is core to how we do communication. So that's a little bit of the framing for today. Just a brief definition about health literacy before we begin. So health literacy from an individual perspective is about how people find, process, understand, and act on health information and services. But that doesn't happen in a vacuum. There are the conditions in which people can do those activities. And so what we're looking for then is that alignment between that context and individual skills and knowledge and resources. And then what we're trying to do is figure out how do we get that alignment to work in a more effective way. So I'm now going to turn it over to Megan Humphreys, who's going to give us a brief presentation on some very interesting data that I became reacquainted with last summer when she was down at the CDC Health Marketing Conference. And she's going to be talking about a couple of decades of research at this point on the Edelman Trust Barometer, and that's going to launch our presentation then in terms of who people trust, for what, and what are the implications then for doing public health communication. So thank you, Megan.
Right. Morning. Awesome. So nice to see you all. I'm gonna move this over. Hi guys, gonna come help me. How many of you have heard of the Trust Barometer before? Anybody? No. One. Yay. So Edelman, as Cynthia said, is a health communications communications marketing firm, and we also have deep expertise in health. And most of our clients are private sector companies and organizations. Actually, Robert Wood Johnson is actually one of Edelman's clients. Every year, we do a global survey on the state of trust in around the world in 4 separate institutions. I will say that this presentation is geared more toward private sector audiences, so you'll see words like companies, customer, industry, consumer, and where possible, I'm going to try to make some tangible parallels or some inferences in terms of how it might apply to your audiences. So, as Cynthia alluded to, and Dr. Vesper talked about this morning, our world is in a period of disruption, right? So we've got disruption in government, in our leadership. Across healthcare, it's being disrupted by news of Amazon possibly getting into the healthcare marketplace. And in response, consumers are more active than ever on issues that they're passionate about. Some in health, some in gender equity. People are really finding their voice and looking to trusted sources of information to their points of view. So a little bit about the Trust Barometer. We've been studying trust for 18 years, and this year we surveyed more than 33,000 online respondents over the course of about a month between October 28th and November 20th, 2017. We study a general population sample, and then we look a little bit closer at our audiences to try to gain more insights. So one of the areas of focus is the mass population, represents about 85% of our respondents, but we also hone in on what we're noting as the informed public. It represents 15% of the global respondents and population. And it must meet 4 criteria: age 25 to 64, college educated, in the top 25% of household income per age group, and report a significant amount of media consumption. So you might call this group the elites. Trust in retrospect. Over the course of the time that we've studied trust, we've seen various trends. And these trends start to emerge and change along with our global and country-specific circumstances. NGOs and experts are historically leading in terms of institutional trust. We see that when trust declines in business, there's a big scandal in the private sector, trust goes up in government. And when trust goes down in government, trust goes up into the private sector to look more for solutions when government is failing to lead. You'll also see on here that in 2005, and I'm going to talk about this periodically throughout my talk, trust shifted from authorities to peers. A person like me is started to appear more and more in our survey results and became, you'll see last year, it actually surpassed the academic and technical experts as a trusted source of information. And this year, the results are a little bit more interesting. we see massive disruption, and this year for our theme, for the big sort of takeaway from the trust data this year is the battle for truth. So information and disinformation in our marketplace is rampant. And how do we as you as health researchers, but we all as collective health communicators fight that battle for truth? So the 4 institutions that we look at every year are NGOs, business, government, and media. So we look at the state of trust across each. And in the informed public and in the general population, the state of trust just crashed. It cratered. It's the lowest reported state of trust across in any year that we've looked at the data. And these are the 2017-2018 drops. What we saw was interesting because now the informed public distrusts as much as the mass population generally. These declines occurred across geography, income, and gender. So this is a universal crash in the state of trust. Interestingly, however, we have seen that while trust is declining, the institutions that previously held a lot of credibility are rebounding. So for the first time we looked at how do people differentiate what media means? Is it your traditional media? Is it your online platform? Is it Facebook where you get most of your news now? And we've seen that over the course of time, these trust levels in platforms and journalism are relatively even, right? They sort of flip-flop. This year, we've seen a massive gap open. People are sort of turning back to the traditional media sources and realizing that the implication of the democratization of information has led to sort of threatening these long-standing institutions in our country. I, for the first time, am a paid subscriber to the Burlington Free Press, where I live in Vermont. So, and realizing that, you know, paying for that credible source of information is really important. We see actually that earned media still matters. So for a long time we were counseling our clients that yes, earned media is important. You want to get in the Washington Post. You want to understand, sort of get on, everybody wanted to be on the Oprah Winfrey Show or the Today Show with their news. That has sort of decreased over time, but now we're seeing real sort of reemergence that communications and media matter. People can't tell the difference between real news and fake news. People don't understand what goes into real news. They can't differentiate it for themselves, and it's becoming harder to decipher that through the web. So trust is down across the board, as I said before. I'm going to focus on the right, where in markets with extreme trust losses, people are turning to NGOs and businesses for solutions. So even though trust in government is at an all-time low, really there's an opportunity here for organizations and businesses to lead with solutions. So I'm going to dig deeper into trust in healthcare. I'm not going to focus on this too much, and this is just sort of some context setting for last year, what happened, the March for Science in April, Tom Price stepping down as HHS Secretary in September, and then with the opioid crisis formally proclaimed, and Cigna and CVS acquisition and the Amazon news, that's the time period that this survey was held. So we see that the trust in the healthcare sector declined, as did nearly all of the other trusted sectors. Technology has been the leading trusted sector for a very long time, I think for the last 4 or 5 years. Financial services used to hold the bottom slot. Now that belongs to healthcare. Part of this could be because of all the debate around the Affordable Care Act law and Obamacare and the confusion about whether that's still law of the land or not. And I'm going to unpack that a little bit. Although I will say that it still receives a 53% trusted rating, so it's in the neutral category. The story isn't completely horrible. When we dive into the health sector, we looked at a few subsectors. So hospitals, clinics, and medical facilities are, I would say, by far the more trusted, most trusted sort of institutions within healthcare, followed by consumer health and over-the-counter industries, biotech, life science, insurance, and pharmaceutical companies occupying the bottom. There is also an opportunity here because, hold on a second. So the opportunity really is that, my gosh. So there's an opportunity here because consumers feel that they have access to the information they need to make healthy choices. So whether they get the right information or not is what we all need to decide, but people feel like they have access to it, whether that is from someone like themselves, like a peer, family member, a coworker, or a trusted source on the internet. And how do we, as purveyors of trusted sources of information, make sure that that content is engaging and seen by our audiences? So we have the opportunity to inform and engage. I'm going to go quickly over these couple of slides because they're only tangentially relevant. So companies are expected to lead. CEOs and the companies that they lead are really seen as trusted areas where you could put out there as a spokesperson or use to engage with publics and audiences. This is only tangentially relevant, but if you work for a CEO, if you are a CEO of a hospital or a clinic or healthcare institution, you have an opportunity to take that credibility and make sure that your information is seen, understood, and acted upon. So I'm going to spend a minute here on the voices of authority that regained credibility. So you'll see here technical expert and academic expert are actually the two most trusted sources of information, and that's really, really good news because there's an opportunity here to put your spokespeople out there and to train them in effective and plain communications in a way that really reestablishes relevant and trusted and credible sources of information rather than the disinformation and misinformation that gains a lot of headlines. A person like yourself is still a trusted source, so we cannot ignore that. But it has dropped 6 points from year to year. Employees kind of emerged in our study this year as one of the most trusted sources of information. So engaging your internal audiences is also really required in terms of external communications because they are seen as really relevant, really authentic voices of what's really going on. The CEO and the press release might say one thing, but if the employees of an organization are also bought into that vision and mission and doing good work, they can be and are expected to be active participants in the organizational communication. This slide is meant to underscore the perception that you have to have a relationship with your audiences. The most trusted content comes from my friends and family, a person like me, or an academic expert, followed by companies that I use. So if you have, if you're a consumer of a particular brand or a shopper of a particular website, you tend to trust that company more than companies you don't use, which is all the way over on the right. So even though this is sort of not quite relevant to what you guys are doing, the relationship piece is what I want to underscore for you. Cynthia, okay if I keep going on my time? I'm giving the high sign.
Okay, 1 more minute.
Okay. So, employees. So what? So for a long time, communications was sort of yielded, just put it out there. What's the famous line from this movie? Right. It was, all of our communications have been built on this fact that if we just put it on a website, well, it's out there. It should be seen. Why isn't it being seen? Why isn't it being engaged with? You must have a relationship with your audiences and push that information out to them. You also need to know more about your audiences. So those of us in public health and designing public health campaigns, if we get to the point where we say we're focusing on moms as a target audience, we think we're being very specific, right? However, that audience is not a monolith. There's moms of all different ages, races, socioeconomic classes, geographies. You need to be thinking that next level deeper about how to reach the audiences that you are hoping to reach with your messages and your information. And take it in bite-sized chunks. You're not going to be able to boil the ocean right away. But if you focus on moms of millennials and figure out sort of where and how they access their information, that is a good start to any health campaign. Anyone know who this is? Yes, Dr. Salk, creator of the polio vaccine. He was a pioneer in his day, not only of health science research, but also of communications. He went out there and told his story to the media. He interacted with the public. He was sort of disdained by the medical community for doing so, but his message got out there that his solution that he was credible talking about really sort of revolutionized the healthcare of the day. So when you think about good science, think about good communications as well, because you need both to be able to be effective. This is just a recap slide of some of the takeaway lessons. Use social media, create a dialogue. Don't just put something on a website and hope people come to it. There are effective ways to use small amounts of paid programming, which purveyors of disinformation and misinformation are using a lot. So there needs to be more use of those channels, specifically Facebook and Twitter, to promote some of your more credible information and materials and content that'll be seen by a wider variety of audiences. Speak with your both head and your heart. In counseling, health experts and technical experts, they're so heavily steeped in the details of what they're talking about, the study, or their information that they have to share. Make it relevant to the audiences. So show why it's important that people understand this new innovation or new health solution, or just the dietary guidelines for that matter. Lots more here. I'm happy to email this around if you're interested, but thank you very much.
Great, thank you, Megan. So think about your questions for Megan while we have our two discussants next comment on Megan's presentation, as well as their own perspective on communicating about health and science. So we've asked them to begin by talking about what their position or role is in communicating, whether they're researchers or teachers or organizers, the audience or groups that they interact with, and the topics that they most frequently communicate about, so you have a little bit of context about who they are before they make their remarks. So we'll begin with Lenny Preston, who is Vice President of Consumer Health First, which is a consumer information, education, outreach, advocacy group here in the state of Maryland.
Great, thank you. Yep, can you hear me? Good. So thank you very much for inviting me to join this. It's such a timely topic. I was listening to TED Radio yesterday and came on again last night, and the topic was trust. And I highly recommend it. I could only listen to a piece of it, but the piece of wisdom I took away from that small minute, was trust allows us to live with what we will never know, which is something we're thinking about. And a headline I saw over the weekend, I think spoke to the issue for today. The headline was, "Health Information Portals Give Patients Data and Dread." So I think that goes to the intersection of health and science literacy and who we will trust to turn that dread into useful knowledge. So let me respond to my questions. I seldom do what I'm told to do, but I'm going to do it this time. So the first one, my position or role. So I've been with the organization for 12 years. We've changed our name in that time, but I started as the vice chairman, or I like to say the chairman of vice. I then moved to chairman, then to executive director and board president. Then I was just president for a while, and now I'm vice president. So clearly they don't know what the hell to do with me. So throughout that time, the organization's work has been informed by health policy, both national and state, and research, and that drives the development of our legislative and policy solutions, to one of the points that Megan made. We then translate those through education and advocacy strategies, and we can communicate them at multiple levels, all of which you can imagine, from symposium and presentations like this to a weekly e-letter. Our constituents, to go to that, primarily they are other policy and advocacy organizations in the state, elected officials, policy and decision makers, and other stakeholders like the Maryland Hospital Association. They then feed in to the much broader audience, which is the public. So we seldom interact with the public directly. So I want to look at trust building through two lenses. One is through the lens of our organization, in order to develop a reliable and responsible organization trusted by our constituents. And the other is to look at a specific project that our organization worked on, where I served as chair of the Consumer Engagement Task Force for the Health Services and Cost Review Commission. It's going to become HSCRC, so I don't lose too much time. So let me look first at the organizational piece of that. With Consumer Health First, we were established in 2006, and from its inception, we embraced Megan's edict to be solutions-oriented, show, don't tell, and placed a premium on trust building because we knew that without that trust, we wouldn't get a voice and a seat at the decision-making table, and therefore we wouldn't be able to carry out our mission, which is to seek solutions and advance reforms to promote health equity through access to high-quality, comprehensive, and affordable health care. So if you yell, "the house is burning down," and you don't actually tell people where the exit are, you're not going to succeed. So we measured our success, actually, in trust in a strategic planning process when we were deciding how to transition from the Maryland Women's Coalition for Healthcare Reform to what we are today, Consumer Health First. And we interviewed several dozen colleagues at the state and national level. And the short answer to whether we were valued and valuable was yes. I'll give you two quotes. One was, "A model for other states. They know the opportunities and challenges in Maryland and are trusted to identify the right steps. They're reliable and we trust their data, research, and recommendations." So that was in 2014, but we know we can lose trust overnight, right? So recently at a legislative hearing, the Maryland Insurance Administration said of the organization, they're a great resource to Marylanders, keep everyone on their toes, playing fair and making sure that we're doing our jobs. Consumers win when that happens. So we built a trustworthy organization that translates into legislators sponsoring our legislation, the insurance commissioner listening when we testify at hearings. I don't think he always hears us, but he listens. Maryland's connector entities provide assistance to consumers, and they use the materials on health literacy, what to do, what to know when you buy health insurance. So they view that as trusted information and trusted resources. We can recruit other organizations. So to a Medicaid collaborative, for instance, that was created after the election last year. We have a new campaign, Medicaid Supports Maryland, that is trusted by those, by the public and others. Thank you. And, but we have to remember that once we build that trust, we can lose it, as I said, overnight. So it is embedded in our organizational culture, and it's why we got invited to chair the Consumer Engagement Task Force for the HSCRC, specifically looking at our state's unique all-payer model. How many of you have ever heard of the all-payer model? Yes, well, I could have picked you up. So it's been in place since January of 2014, and most people still don't know what it is, and yet it has a tremendous impact on our lives. It was a new model to leverage Maryland's unique hospital rate-setting system in order to drive value at volume at hospitals and to address the triple aim. It has enormous implications for individuals and how care is delivered at hospitals, implications for the hospitals, the healthcare industry, but it's very clear that this little project needed a large campaign, education campaign for the public and those even providers and others. So in the work to create a report over 9 months, one of the things we discovered in focus groups was that people trusted the state agency, HSCRC, to carry out this new experiment. That was in 2013, in the fall. The spring of 2013, actually, when they named Maryland's Health Benefit Exchange, it became marylandhealthconnection.gov, not .com, because people trusted the government back then. I'm wondering if we tried that today, what it would look like. So the report that was published in 2014 by this Consumer Engagement Task Force, which is online and makes great bedtime reading, we define consumer engagement as engaging individuals in the health of in their own health and in their community's health. There are 3 areas I think intersect with the topic today. I'm not going to cover them all because I now only have about 30 seconds, which I'm not going to make. One is health literacy. How do we define that for the purposes of effectuating consumer engagement? How do we evaluate effectiveness with scientifically valid performance measures? And who are the most trusted communicators? So there were several overarching themes that relate to trust in this work that we did. One is that healthcare information should be disseminated and consumer engagement activities should be led by sources that consumers trust. So remember, the all-payer model relates to hospitals, and think about the headline in the Baltimore Sun in February of 2017. It read, "Johns Hopkins Hospital inspires mistrust and fear in parts of East Baltimore." That's a problem if they're giving information to the public. The second overriding theme of 10 was trust, dialogue, and collaboration and shared decision-making produce better outcomes. So we identified the most trusted messengers. It's interesting when I looked over that we did not include in that list family members and others that we know personally. We were looking at the construct of the system as a whole. We identified the messengers for 3 audience sectors. And then we also, a point I think is important is to think about this, is the timing of messages, because you might have a trusted messenger at one point in the flow that wouldn't necessarily be the trusted messenger at another point. And the point at which the message is delivered is critically important. It's no good giving somebody a message at the wrong period of time. It won't be a trusted message at that point. One other point I just wanted to make, I think that's relevant to trust building, is transparency. So when we think about that, just within the concept of this all-payer model in the hospitals, transparency on the hospital's part about what the costs are, where people can go for grievances, appeals, I think that's a very important thing for everybody to consider. So thank you. I look forward to questions. Sorry I went over.
Thank you, Lenny. You've given us even more to think about. So our last speaker before Lisa's going to take us to the audience Q&A is Elsie Stein, who holds a number of different roles at the University of Maryland, Baltimore. I'll let her tell you a little bit about what they are. She's going to address the same opening questions as Lenny, and then as a practicing clinician, talk a little bit about these same issues from her perspective, working in the trenches every day, serving patients and educating the health professionals of the future.
Thank you. Good morning. So I'm Elsie Stein, and I have a joint appointment with both the University of Maryland Medical Center as a pediatric nurse practitioner, and also at University of Maryland, Baltimore as the Assistant Vice President for Special Projects and Initiatives, focusing on health and education in West Baltimore, and that's in the Office of the President. I've been doing that for the past 8 years. So today, my perspective is a little different, but I'm going to give you an overview of one of the programs that I oversee and coordinate, which is called President's Clinic. And this is a weekly interprofessional educational clinical experience where students from all of our 6 professional schools, nursing, pharmacy, social work, dentistry, medicine, and even law, come together to learn about team-based care. And they come together to learn about team-based care and how to work together as a team, and then also have an opportunity to see patients together as a team. And so the students attend 3 consecutive sessions, and the first hour is a didactic session where they learn about interprofessional education, they learn about the scope of practice, they learn about myths about their profession, because developing trust amongst their peers is important. And then they also have an opportunity in the second and third didactic session to learn about the social determinants of health, which includes health literacy. And so students learn that where you live, where you work, where you play, can result in poor health outcomes. And across the street from University of Maryland, Baltimore is West Baltimore. And so unfortunately, that neighborhood, and that's our neighborhood, they really struggle with health and poverty and education. And so there are a lot of challenges there. And so the students begin to learn about how patients may come in and may not be compliant for particular reasons. And a lot of times it's because of where they come from. And so that's what they learn in the didactic session. So then what they do is they learn what they've been taught in the classroom and kind of put it into play. And so they go in and they see the patients together as a group. And they learn again in the didactic section about the health literacy. And they have an opportunity for us to, in a sense, critique them. So, you know, they learn in school, in the classroom, about health literacy. But putting it into practice is sometimes a little bit more challenging and can be very difficult. So therefore, Dr. Perman and myself, we give them the opportunity, to demonstrate what they're learning and to be able to put these into place. And so we also, Dr. Perman and myself, we model for the students how you can, the importance of health literacy. And so I believe that to understand health literacy, you have to really build trust first. And without building trust, patients, families aren't going to really hear anything. And we have to remember and remind our students that in Baltimore, just like Lenny said, like at Hopkins, there's a lack of trust in our neighborhood. And we have to be able to build that trust back up. It's essential. So we explain to our students and their families early on during the visit, we try to develop this trust. And so I teach, and Dr. Perman and I teach the students, if a parent's going to be able to tell immediately if you really care, or are they just another patient coming through the door with abdominal pain? So how do we teach that? It's kind of challenging, and so often we just try and model. So we talk about, because when the students go into the room, there's about 5 to 7 of the students, and sometimes they all walk in and they're all standing over the patient, and so that's extremely intimidating for a family. And, to have everybody looking, they're looking up at them. So I always encourage the students to all bring their little stools in, and they sit, and they're at eye level with the patient. That makes the biggest difference to a family, So we talk about when you come in, to make sure you introduce yourself, sit down, don't stand. Make sure that you sit close to the family and have good eye contact. And that you have to be engaged and listen with energy. You can't kind of just be there taking your notes. You have to really be engaged, and families can tell if you are engaged or not. And making sure that you give an opportunity for the families to give their history. Don't interrupt. Don't assume that they're coming in for constipation, and in your mind you've already got a plan ready and you're not listening to anything else they have to say, because you might miss out on some critical information. So it's important for the students to be able to understand that with health literacy, gaining that trust is just the opening. So if a family believes that you are invested in their child, they're going to listen better, and they're going to feel more comfortable in asking questions. And so showing some empathy for the families, developing that relationship. Now, medical jargons is obviously an important piece. Often the students may go in and they might say, are you having any nausea? And, the child might say no. And then I might stop them and I'll say, do you know what nausea is? And the child says, no idea. So, then I'll say, okay, let's think about this. So when you're having belly aches, do you ever feel sick to your stomach, like you want to throw up? Oh, yeah, I always have that. So it's important to break it down. So medical jargon is important, and often we forget. I mean, it happens to me. Sometimes I might say, any history of GI disorders. The families don't know what GI disorders are, so I have to break it down. Are you having any trouble with anybody in the family with stomach problems, with issues going to the bathroom, with blood in the stools? So making sure that you think about the words that you're using, and making sure that you make sure that you have the family feel comfortable in being able to say, I don't know what that means. So I see I'm almost out of time. I can't see that far, but I think I'm out of time. So I can use that as an excuse. But I'm going to leave you with one story. Often in clinic, patients always will say, or other providers will say, send that patient to Elsie. I don't know how she gets them to be compliant, but send that patient to Elsie. And so I had a patient who came in to see me that had seen 3 different providers. Patient mom wasn't doing anything they told her to do. They couldn't understand this patient had a gastrostomy tube. There's no reason why this patient shouldn't grow. And the patient continued to was failure to thrive, continued not to grow, despite having access to give nutrition. And so I sat there for half an hour, and I couldn't get anything out of this mother. I struggled, and I didn't have any more time. I only had my half an hour. So I said to the mom, you know what? I care about you. And, CPS was going to get involved. And I said, can you come back tomorrow? It's an admit day. Let me get a little bit more detail. I want you to bring that pump in. I want you to bring the medications in. Because she just kept on saying, I'm doing everything that they said on the paper. So after about 45 minutes the next day, I said to her, you know what? I hope I'm not going to offend you, but do you know how to read? And she said, no. I have a learning disability, and I have no idea how to read. And so we had to be creative. But this is nobody ever thought. They just gave her the piece of paper and said, here's your discharge instructions, go home. And so, we became creative. We were able to do the sun and the moon for night medications and daytime medications and label syringes. So when you develop that relationship and you develop a trusting relationship, a lot of times the families will become more comfortable and be able to say, you know what, I don't understand, or can you explain that a little bit more in details? So developing for us in clinic, we teach students developing a trusting relationship is the first step into health literacy.
Thank you, Elsie. Put something up here. The purpose of this session is really to bring the 2 campuses together. together, and also to help you in the audience with trust and literacy issues. So before we go to the Q&A, just want to see who's in our audience. May we see a number of hands who are students, undergraduate students first. How many of the undergraduate students are pre-healthcare students? How many postgrad students do we have? How many clinicians do we have? How many healthcare faculty do we have? How many healthcare researchers do we have? How many folks who work out in health departments or public health? So it seems like from the research data we've heard from our keynote, from our speaker, and then the down in the trenches experience from Elsie, that perhaps we all can hopefully use this information in our work. So before we go to the Q&A, I want you to think about how some of this information can help you and gear your questions to your work. So love to see some hands with some questions for our speakers, whether they be on the consumer level, healthcare level. As a student, you are probably learning all this great stuff in your classes with all these big names. But when you're with patients, my experience is low-income patients, rural and urban. And a lot of what we teach our students, I work with dental hygiene students, the patients don't understand, and therefore they don't trust, and then they're charged, and then they further don't trust. So I open it up to you to ask our panelists questions that can help you. Is there someone with a microphone who can stand up? Wait 1 second.
Better? Hello? Hi. Did that, yeah? Hi, so I'm Allison Goss. I work for the Maryland Department of Health on climate change, and one of my questions about communications is with languages, so a lot of Spanish resources. A lot of the communities we work in ask for Spanish resources, and unfortunately at the health department, there's strict guidelines, there's cost prohibit, how do we build the trust and include those communities with limited resources? Are there partners that we should be bringing in to kind of help with that? So that's my question.
What we find in building communications products for many different languages is we try to bring some experts in from those communities from the beginning, at the outset. Whether it's someone from a local organization who you could perhaps fund for their time, or a volunteer from a member of that community from an organization who's committed to the mission of building healthcare in those audiences. In terms of translation services, we found that most of them will charge you, but also the products themselves may not be as effective because you've just simply translated something you've created for a mass population into Spanish, and the audiences won't necessarily respond. So co-creating that with the community in mind is definitely really important to do.
Yeah, I would just pick up on that and say, so we do a lot of partnering with CASA of Maryland, for example, who is a tremendous resource and can bring in others who can help with a project like that. And think about other mediums besides just the standard print. There may be other ways to actually spread the message further without doing print materials that have to get distributed in sort of the normal way. So it may be more cost effective to do it in different ways than what we think of as the traditional way. But I think the most important is to bring in groups like CASA or others in the local communities, as Megan said.
I was going to say, at the hospital we have interpreters, so we will often schedule those interpreters in advance. So if a family calls to schedule an appointment, we ask if there's any, if English is their second language, and automatically every patient that whether they speak Spanish or French is entitled to an interpreter. And if for some reason we don't have an interpreter available, then we use the phone line system, and that is a requirement. We have, some students who say, oh, I speak some Spanish. We can't use those individuals, and that it has to be a certified interpreter. It can be challenging, though, when it's on the phone. It takes a very long time, but it is important because that's the only way you're going to really educate the families of the patient.
Hi, I'm Erin Hager with the University of Maryland School of Medicine, and I work in the Department of Pediatrics, so I work with kids. And I have two kind of comments and questions. One is about 10 years ago or more, we were able to, as public health researchers and practitioners, to really mobilize the antitrust movement to fight tobacco companies and kind of get people excited about not trusting people. And so I'm just wondering if we're at that point now in this climate of antitrust, or is it too messy to really kind of mobilize that to actually help people change their behaviors in positive ways? And then because I work with kids, Shape America, which is the Organization for Health Educators and Physical Educators, recently added advocacy to their health literacy definition and talked about advocacy for your own health and for the health of others. And so again, kind of in the context of trust, what are your thoughts about adding advocacy to the definition of health literacy? So again, two related questions.
I'll pick up on the first one. So, questioning our established institutions, whether they be the tobacco industry or the government, is a both healthy thing to do and something that inspires good dialogue. I don't think we've over-indexed on mistrust because there have been well-founded reasons why people stop trusting nefarious industries, companies. Whistleblowers are very valuable to our society, and I still think they remain so, which just underscores the importance of being authentic and credible and transparent, like Lenny said. I think while those instances should have gotten sort of outed from a trust perspective, we've sort of all started blowing the whistle on each other. So I think if we start communicating within our organizations or continue communicating within our organizations in an authentic and trusted way, those organizations in the long term will be successful. And those who are not behaving or in the interest of our public health correctly, they will continue to sort of be outed or targeted for their mistrusting.
So, yeah, as an advocate, I'll take on advocacy and health literacy. I mean, I personally think that's a no-brainer because, I advocate 24 hours a day for health literacy, among other things. I touched on this earlier, but we devised a graphic for what we call the path to consumer engagement, which is a 4-step process with little steps in between. But it starts with financial literacy and then moves to health insurance literacy. The third step is health care literacy. So I get this plastic card, what the heck do I do with it? When we think about the ACA and all the people who got health insurance for the first time, and they have no idea what a primary care provider is. So how are we going to end up driving down costs and getting better care unless we actually help people to become literate on that health care piece of it? And then the fourth and final step is the individuals who have passed through those first 3 phases, have ownership of their own health. But at that point, they actually look around. And so Jane Doe has overcome multiple chronic diseases, sees a doctor regularly, exercises, eats well, doesn't do all those terrible things you're not supposed to do. But she looks at her neighbor John next door, who has diabetes and other issues. He's not going to the doctor. And she realizes he has no car, minimal family, and there's no bus nearby. And so she becomes a civic activist and an advocate for her neighbor and goes to the city council and says, look, we need a bus route. So I think if we think about advocacy and health literacy within that sort of larger context of full consumer engagement at all levels.
I think to pick up on the question that came up in Dr. Besser's session this morning, there's also the environmental health literacy piece. And so I think there's the social determinants, but there's also the environmental and political context that would suggest it would be in people's best interest to also become advocates. So I think it's very aligned with what the concept should be, as well as a couple of different models of health literacy that are already out there.
I would just say while we're waiting for the question, advocacy doesn't come naturally to everybody, so really people have to be empowered with accurate information in order to become effective advocates.
Hi, my name is Gabby Taylor, and I'm from the Prevent Cancer Foundation. I work on campaigns, and right now we're running a campaign on viruses that cause cancer. And my question to you is what advice or what best practices are out there for increasing health literacy of immunizations and vaccines with the general public? And also, what role do celebrities, if any role, can they play in helping educate people on the true information on immunizations and their benefits to society?
First, I would start with who's your audience. So knowing as much as possible about who you're trying to reach with your campaign will set you up for success. And I mean as much information, like where they live, who they talk to, where they shop, informing your campaign with data and research is absolutely where you should start. There's a lot, I chose Dr. Salk for a reason, because today we have robust discussions about the value of vaccinations and the misinformation and disinformation that's out there on that issue. I think that having that sort of seeing that rise in technical experts and academic experts will be helpful in terms of the broader narrative. But I also think in communities that have either distrust in medical systems or like communities of color, or people sort of in the middle of the country who question whether the vaccines have caused their son or daughter to have autism, you need sort of that peer-to-peer communication. So using your academics to sort of give the big message, the credibility message of why immunizations and vaccinations are so vital to our communities, but then choosing sort of more peer spokespeople so that you can engage in communities that are distrustful or fearful even, to deliver those messages to the more skeptics who aren't going to listen to that technical expert, right? It's just going to say, well, I have a technical expert over here who says otherwise, right? I do think that the engagement and trust in changing hearts and minds needs to happen at that peer level. And starting a campaign with people who are sort of the advocates, the loud voices in support of your messages as sort of ambassadors, if you will, for communicating your messages, is empowering them and giving them the tools and the platforms they need to communicate can be a first step.
Well, we just launched in February MedicaidSupportsMaryland.org. It's a public education campaign about the value of Medicaid with the goal of destigmatizing the 1 in 5 Marylanders that are covered by this public health insurance program, and therefore destigmatizing the program as a whole and demonstrating the value of that program to the state's economy. And so to pick up on one, I can talk about it all day, but one point I think is the value of the information that is provided on that, the fact that those are trusted sources, and it's completely nonpartisan, which, you know, there are always challenges with that. Let me just give you a quote that Ashley Parker of the Washington Post said. I heard her this summer. It's just too good not to share. She said, "The definition of fake news is fact-free information." So we do not have fact-free information, but the other part of it is the importance of the individual story, of bringing this down to that individual level so that we can recognize and feel empathy and a personal connection with those people that we're talking about, whether we're selling in quotes, immunizations or really whatever it is.
And I would just say that, you know, on a different level, as far as, you know, a clinician, again, building on that trust, because I've had patients who come in and it has nothing to do with their child, and they'll say, you know what, Elsie, I want your opinion. What do you think about getting the flu vaccine? What do you think about, and this has nothing to do with their child, it's with their own, you know, it might be with their husband or another child or for themselves. And because they have, we've developed this trusting relationship, they feel that what I'm saying is right, is true. So, and on a clinician level, it's again building on that trust.
I have a question along those lines, if I may ask. How do you deal with patients who get their information from Facebook or a friend that just may be incorrect? I myself deal with, up in Cecil County, where there's no fluoride in the water. I'm a dental hygienist. And they hear it's poison. And I tell them, as we teach our students, it's from the research, it's from the science. So they don't want to hear it. So what's your advice?
So, you know, I do get patients who, when I try to share with them research, a lot of times they kind of dismiss me, but sometimes if I relate it back to myself or to family members, a lot of times they will want to say, if this was your child, you know, what would you do? But again, I think it goes back to developing that trusting relationship, and that, you know, and I say, you know, this is research, this isn't going to benefit me in any way, but they've done studies, and I break it down on how the research is done. And so often that might help. And sometimes it takes time. You know, you don't develop this relationship in one visit. Sometimes you can, but sometimes it takes, you know, quite a few visits before they trust you and feel comfortable and believe what you're sharing with them. But it is very challenging.
And I will add that platforms like Facebook and Twitter and the social, putting the public health messages on those platforms to at least appear alongside the misinformation is important as well. Like, we shouldn't just cede the platforms to the dribble. We should also sort of make sure we have an equal voice or equal time using those platforms to communicate.
Yeah, and don't forget Yelp. We were doing a survey for the Consumer Engagement Task Force, so I decided to go on Yelp and see what people were saying about hospitals. It was pretty amazing. And we all know that, I don't know about you, but we all use Yelp. I mean, my daughter doesn't go to a restaurant unless she Yelps, right? So we shouldn't forget that.
Hi, I'm Mary Joseph from the Primary Care Coalition. And I just wanted to pass on what I do and ask for any other feedback. When I'm addressing students or professionals and we're talking about health literacy, I often approach them in terms of automotive terms. So they're smart, they all have cars, but when I throw out 10 or 15 automotive terms to them, they have no idea what I'm talking about. And even if they've heard the terms, they don't know how it makes their car work and what the impact is going to be. So in dealing with that, I say, well, you might lose $1,000 or even a couple $1,000 if you make a mistake and don't understand this, and you won't be able to get around. But with your life, it makes a big difference. So people out in the community who aren't health professionals, it's the same thing. They don't know the jargon, they don't know. But I was wondering if there are any other best practices, or especially Elsie, I know you work with the students a lot, to kind of help them see reality check. That here's something that I would do.
So, I think that, that's a great analogy there with the cars, and I might have to use that one. But I think because I've been doing this for so long, I do it and I don't even realize I do it. So when the students have an opportunity to, I'm able to model, or Dr. Perman's able to model in front of the students, often when we're doing the debriefing session, they will say, I never thought about, that because I said GI disorders that they wouldn't understand. And also with us having that interprofessional education clinic, the social work student may say, you know what, you didn't ask that the right way. You didn't, or, you, and it's not in a disrespectful manner, but, for the students to be able to maybe pick up on how things were asked of the patient. They learn from each other. I'm trying to think as far as, for me, I talk to the families, often when I'm talking to the child, the parents, because sometimes they're uncomfortable or they're embarrassed because they feel like this is something they should know. So when I'm asking the child, when I talk about nausea, or do you have mucus in your emesis, the medical student or nurse practitioner student might say, do you have mucus in your emesis? And so when I get so many no's, I'm thinking something's not right. And so I start to, be able to break it down. Do you know what mucus is? A lot of times, if they do know it, that's fine. But at least they're able to see that, simple words to us that we use often, mucus is something you use all the time. But to them, that's not a word in their vocabulary or a word that they use. And so I think it just takes time. It's not something that you can go study and learn and be an expert. It takes time and you learn from your experiences.
I just want to make a couple of comments about that. So with clinicians who might have trouble kind of recognizing why vocabulary in particular is challenging, a lot of times it's helpful if you can encourage them to either accompany somebody else, as in that caregiver or family member role, especially if it's going to concern an area that they're not expert in. So for example, we often hear that physicians have that light bulb moment about health literacy, that when somebody in their family gets a diagnosis about something that's not in their specialty and they accompany that person to the medical appointment or are in the hospital with them, and they suddenly are in the front of that fire hose of information and jargon, and then they, have that experience and say, oh, I get it now, I've done that. From a communication research perspective, so I was at CDC for many years before I came to Maryland last year, and my colleagues who worked on the campaigns and other programs across the agency would say that the most powerful thing in that context was when they would take the scientists, the epidemiologists, the physicians behind into the focus groups and behind the mirror and let them watch people actually interact with their materials. And the scientists, their mouths would drop and they say, I had no idea that people didn't understand that. And I'll just give you one last example. So during Ebola, I was involved in doing review of communication materials. And, obviously there were a lot of body fluids involved with Ebola. And so I was arguing that we had to use the word poop. We had to. And people were like, we're CDC, we cannot say poop. And I said, in a public health context, the heavens open. I have been published by the Jargon gods. So anyway, that was a battle we fought, but then if you look at, for example, the Division of Waterborne Diseases, they run a poop in the pool campaign now. Why? Because they're trying to target lifeguards. Who are lifeguards? High school students. Moms who take their toddlers to the pool in swim diapers. And, older siblings who take their younger siblings to the pool. Who do they want to reach? People who know the word poop. So I think, we just need to be really realistic, back to what Elsie said, realistic about the words that people know and use in everyday life. And just one last thing is I have a colleague who talks about this as living room or kitchen language. If you think about how you talk in your everyday life, that should be how we talk when it comes to public health messaging. So other comments or questions from the audience? Okay. You have the...
I'm actually sort of afraid of it because it might make weird noises.
Just don't say poop.
So I'm a pediatrician, and I'm also a health officer for our county. And first, the answers you guys gave were awesome to that question. When I'm dealing with people who go to Dr. Google or I'm being insulting, because sometimes we don't want to talk down to people because we think we'll insult them. That explanation helps them not be quite so insulted that I'm talking to them like they're in third grade. And once they break that barrier, then they can turn around and say it. And in hospitals, we use teach back, where you tell someone something and then say, can you explain to me what I told you? Or tell me how you explain that when you went home and talked to the grandma or the nanny. And that, I think, also helps with good health literacy and good communication. And hopefully finding Dr. Google and expectation of faith.
And I would say also that for Teach Back, it's important because sometimes the families will say exactly what you said, but they really don't comprehend and they really don't understand. I mean, people think I'm actually crazy because at the end of every single discharge instruction that I give the family, one, I make it so it's not so much information because that's overwhelming for the family, but I put my cell number. And people say, Elsie, you've got to be out of your mind. You must not get any sleep. People call you all day long. And to be honest, I don't really get that many calls. And it's because I take time at the end of the visit to really make sure that they understand what I said. Why are we doing this? Can you do this? Sometimes we will say, go across the street to the Rite Aid and get some Miralax for poop. And the residents will say, just go across the street. And I'm like, well, you already said there's struggles of getting transportation here, putting food on the table. Can you pay $15 or $20 to go across the street and get Miralax when I can give you a prescription that's generic and it's going to be covered? So sometimes we just, things like that students need to hear, because $15 to us, to me, is a lot of money, but to some people they might not think it's a lot. But also with the Teach Back, making sure that it's just not them rehearsing or saying exactly what you said, and that they really can break it down and explain what you've just, what's going on physiologically or pathologically.
So we just have a couple of minutes left, and I noticed that when Lisa asked, the majority of you who raised your hand identified as students. We didn't have that many faculty. We did not have that many researchers in the room. So I'm curious from the student perspective, is there anything that you would like to tell us, since you have several faculty members up here and other people who can influence faculty behavior, what would you like to have faculty know about your interest in health and science literacy? Are there things that you think you should be getting more of in the curriculum, or would you like to have more research opportunities or more practice opportunities with organizations like Consumer Health First or with the clinic that Elsie runs? I mean, from a student perspective, what would make this topic more real for you?
This gentleman in the white shirt.
I don't need that mic. So I was at a Easter dinner over the weekend, and I had to deal with anti-vaxxers, and I felt so unprepared. But we talk about the science and the research and all the evidence that we have, but I felt so unprepared as a research public health practitioner that I like to call myself, and I just didn't really know how to interact. And so I think that's really important that while we're getting our training, that we know how to handle conversations at Thanksgiving and taking these things back to our families. And I think that's a really
Plain language.
I would like to have more training.
Plain language communications is critical, both when you're thinking about communicating with your friends and family, but also, the public. I think where we have advanced in our education and our knowledge of any particular area, you sort of get presented with the misinformation and disinformation, and you're sort of like frozen. You sort of don't know where to start, right? So, I would echo any curriculum that is focused on sort of plain language, and translating science into plain language is a critical need for the sector.
All right. Well, any other last words?
I have a question for the audience.
All right.
Those of you who are students, especially healthcare students, could I see a show of hands if any of you have, in any of your courses, do any role playing? You. What type of students? What area? Nursing. We do it in dental hygiene as well, but what I find is they learn so many of the technical terms that when they get down to the role play assignment I give, they freeze. And so it just goes to show you that there needs to be more